Well, I want to welcome everybody to today's Grand Rounds. I know Mark really wanted to be here to provide his reflections on the Children's National Global Health Initiative, but unfortunately had a family emergency. Our Global Health Initiative is only 2 years old, yet we already have a great deal to be proud of, and this week is clearly a testament to that. The mission of the Global Health Initiative is to support global health research and education at Children's National, addressing pediatric health disparities around the globe, and at the same time advance the careers of faculty, nurses, trainees, and other staff here at Children's. I want to thank Mark, Elizabeth, and Kurt for their support, and Andrea Beaton, Kathy Farrar, Linda DiTilio, and Rachel Sternacki for their tireless efforts in moving this forward. It's an honor for me to introduce today's Grand Round speaker as a testament to the impact an investigator at Children's National can have in global health around the world and here at home, embodying the mission of our initiative. Andrea started at Children's in 2009 as a cardiology fellow after graduating from Center College in Kentucky, the University of Louisville School of Medicine, and Mount Sinai in New York. I don't have time to detail Andrea's early honors and achievements. I wanted to highlight one award, her receipt of the Center College Alumni Award in 2013, where she had graduated both as valedictorian and Female Athlete of the Year. A quote from the person giving this award sets the stage very nicely for her biography. This is the quote. "I should warn everyone to take a deep breath before we begin to note even a few of the extraordinary young women's accomplishments. Just reading this is going to leave me tired, but she does it all with an ease that makes her achievements even all the more admirable." Andrea joined our faculty in early 2013 and has focused much of her time on research in rheumatic heart disease, or RHD. As you will hear from Andrea, RHD continues to have a devastating impact in underserved regions, and several critical gaps in research and clinical care remain. We have a long-standing collaboration in Uganda dating back to 2002 that originally focused on treatment of congenital heart disease. During the first several years of this partnership, the cloud of rheumatic heart disease weighed heavily on our program, yet we had few solutions for what we thought should be a preventable disease. When Andrea proposed that her fellowship research project screen 5,000 Ugandan school children with echocardiography to determine the prevalence of RHD, I was hopeful this could help lay a foundation for ongoing research in collaboration with our partners there. Although it was a lot to place on the shoulders of a second-year fellow, it was clear to me that Andrea would be able to pull it off. The results of this work were published in Circulation in 2012 with Andrea's first author and named one of the top 10 most significant research accomplishments in cardiovascular disease and stroke by the American Heart Association in 2012. This work paved the way for Andrea to receive a KL2 award and continue her research in rheumatic heart disease and join our faculty. Even with the early success, I would have never imagined what would follow over the next 5 years. She has published 40 manuscripts and has a first author circulation paper in press. 34 of these are on rheumatic heart disease and 5 in other important global health diseases. Highlights include a recent New England Journal of Medicine publication on the global burden of rheumatic heart disease, the 2015 Jones criteria, multiple innovative designed research projects, and co-authoring of reviews with the global leaders in our field. Her track record of grant funding is equally as impressive. She is or was principal investigator for multiple academic and foundation grants for rheumatic heart disease work in Uganda or Brazil, totaling over $5 million. And these include 2 new exciting grants in this academic year you will hear about. She also serves in leadership roles in several national and international societies and program committees. Looking at the impact of Andrea's work tells an even more compelling story than just listing her accomplishments. She is recognized as being part of a small group of global leaders whose research is addressing critical gaps in reducing the burden of rheumatic heart disease, the world's giving a voice to what was, for decades, one of the world's most forgotten diseases. In Uganda, she has helped establish and grow infrastructure at the Uganda Heart Institute that now extends to several locations around the country. As the only tertiary cardiac care center in the country of 40 million people, the importance of this on all aspects of patient care, including surgery and catheterization, cannot be overstated. 2 towns in northern Uganda have benefited from the establishment of access to clinical cardiac care that did not exist until recently. As a result, hundreds of patients are being treated. All of her projects, publications, and grants include students, nurses, fellows, and/or faculty members in Brazil or Uganda, in many cases having a significant impact on their careers. Her impact as a mentor here at Children's is also quite significant, as you'll hear today. Numerous Children's fellows, residents, students, sonographers, and research staff have participated in her work, several being on the ground in Uganda and Brazil. I counted at least 12 children's trainees listed on her publications, 5 of whom are first authors on at least one paper. Her commitment to mentoring extends beyond her work in rheumatic heart disease, taking the lead on the research component of our Global Health Initiative that has already awarded 5 internal research grants in global health to faculty and trainees at Children's. On a personal note, it goes without saying that Andrea has had a major influence on my career. Partnering with her on moving the needle on rheumatic heart disease and advancing global health research make every day at Children's more rewarding to me. Her amazing work ethic, discipline, and focus are only matched by her overwhelmingly positive attitude, warmth, and humility that impact me and I know rub off on colleagues, staff, mentees, patients, and families. Although we still have many challenges to overcome, I am so grateful I'm part of the story that Andrea is now going to share with you.
Good morning. Thanks to Craig for the great introduction of this work, which has really, as he said, been a huge team effort. Today I'll talk about global disease disparity and why we need to re-examine what we thought we knew about rheumatic heart disease. And I'll also give you the chance to hear directly from some of our team members that have been on the ground in Uganda. So first, just a quick review of the understood pathogenesis of rheumatic heart disease. A disease once coined childhood's greatest enemy, referring to its reputation for causing high levels of pediatric death and disability. So the classic teaching is that rheumatic heart disease begins with a simple and common streptococcal infection, classically a strep pharyngitis. Left untreated, some people will develop antibodies to group A strep that cross-react with host tissues and result in a systemic inflammatory reaction known as acute rheumatic fever, which involves the joints, the heart, the skin, and the brain. While most of the symptoms of rheumatic fever resolve and leave no lasting damage, the damage to the heart can be permanent and progressive, leading to the chronic valvular heart disease, rheumatic heart disease. And chronic rheumatic heart disease can worsen over time, both from ongoing inflammation and scarring from the first episode and from repeated episodes of rheumatic fever, leading to complications including heart failure, stroke, infective endocarditis, and rhythm abnormalities, which drive the premature death and disability that occurs from this disease. Along this continuum, we believe that penicillin has the power to halt disease progression. If given at the time of group A strep, it can prevent rheumatic fever and rheumatic heart disease. If given after rheumatic fever, it makes it less likely that you'll get rheumatic fever again and can allow time for the heart to heal. And if given after rheumatic heart disease is diagnosed, it can limit the progression of disease, decreasing the morbidity and mortality. But it wasn't that long ago that rheumatic fever and rheumatic heart disease were important childhood illnesses in the U.S. Can I see a quick show of hands of people who have taken care of at least one patient with rheumatic fever or rheumatic heart disease? So almost everyone has seen one. How many people have seen more than 5 cases? So what you can see here is that this is a disease that's generational, not to point out. So with most current trainees, rarely encountering a patient with rheumatic fever or rheumatic heart disease in their career. So what has happened here in the U.S.? So in the late 19th and earliest 20th century, before rheumatic fever had been separately defined, sore throat, fever, rash, and the joint pain, shortness of breath, and disability that often followed fell under the term scarlet fever. As early as the 1960s, we knew that scarlet fever was contagious, that it occurred in epidemics, and that had a high mortality rate both in the acute period and in the years that followed, where there was a generation of children who never quite recovered from those fevers and suffered early death. In this era, in the early 20th century, rheumatic fever was the leading cause of death in individuals between 5 and 20 years. And in 1938, there were more than 1,000 deaths just in New York City, and 8% of autopsies at New York Presbyterian Hospital showed evidence of rheumatic heart disease. It was also in this time that entire hospitals were built for the care and convalescence of patients with rheumatic fever. Here we see the House of the Good Samaritan, which is where Dr. Jones from the Jones Criteria did all of his work. Also, most major cities had convalescent homes for these children on the shore or on a farm outside of the city for children recovering for months from rheumatic fever episodes. Even before strep was linked to rheumatic fever, it was known that if you took children out of the city, out of the conditions of crowding, that they recovered more promptly. The gravity of rheumatic fever during this period is also captured by the frequency that scarlet fever and rheumatic fever appear in children's literature. Here in 1968, when Alcott writes of Beth's death from heart failure years following her scarlet fever episode. In 1922, when Williams captures the plight of a young boy with scarlet fever in his rabbit, the boy's bedridden for weeks and then sent to the shore to convalesce. And in 1939, when Wilder reminisces about her family's time in the West and that so many people had scarlet fever that there was no one left to work. But this was also the area of great discovery and rapid progress was being made during the early 20th century. In 1928, Alexander Fleming discovers penicillin, though it's not yet in mass production. Shortly after, Coburn and others make the link between strep and its resulting rheumatic fever. And quick on their heels in 1935, Dominic discovers a sulfa antibiotic, which is the first mass-produced antibiotic that's effective against strep. At this time, there was great hope in our nation that rheumatic fever was starting to decline and the pieces seemed to be coming together. However, the start of World War II in the 1940s resulted in the assemblage of large groups of young men and provided the conditions for rapid spread of strep. And what we saw was epidemics of rheumatic fever among the military recruits. Between 1942 and 1945, there were over 40,000 cases of rheumatic fever in the U.S. Navy, and platoons were reporting 25 per 1,000 affected, with some reporting up to 100 per 1,000 soldiers affected by rheumatic fever. On a more positive note, World War II provided a strong impetus for moving penicillin from discovery to mass production as the first-line drug to help treat battle wound infections, and as a secondary result available for strep treatment. And the war was also a powerful motivator for Dr. Jones to formalize his work in developing standardized criteria for the diagnosis of rheumatic fever. To quote Jones, "A more immediate stimulus has been the appearance of rheumatic fever in the armed forces in such volume as to consider this a serious medical problem." And on June 16, 1944, a document with recommendations that looks remarkably similar to our Jones criteria of today was published. Importantly, and we'll get back to this later, Jones intentionally made these criteria highly specific for rheumatic fever, as he was concerned about the exclusion of able-bodied men from the military. He says there's a danger in the criteria. He says there's a danger of producing suffering among patients and parents if too liberal a criteria is applied, and this is particularly important in the armed forces. Around the same time, we also see advocacy efforts beginning in full against rheumatic fever in the U.S. In fact, the American Heart Association was founded in large part out of a shared desire to control rheumatic fever and to understand it better. And its work to educate the public about rheumatic fever represents one of the AHA's most successful public health campaigns to date. So together, and really over a period of little more than 50 years, research, education, advocacy, and honestly a bit of luck led to the dramatic decline of rheumatic fever in the United States until in the 1970s and 1980s, it was considered nearly eliminated from the U.S. and other high-income settings. So now to today, to the current global burden of rheumatic fever and rheumatic heart disease, which continues truly as a disease of disparity both around the world and here at home. So globally, the burden of rheumatic heart disease remains enormous and is largely shouldered by the bottom billion of the world's poorest people. Over 80% of children still live in a country where rheumatic heart disease is endemic, and there are over 33 million prevalent cases currently. There's also a high morbidity associated with rheumatic heart disease around the world, with an estimated 10.5 million disability life years lost each year. Here in red, you can see the highest burden is in sub-Saharan Africa and Southeast Asia. But new data also supports the idea that rheumatic heart disease remains relevant here in the United States and affects our most vulnerable populations. This is a map that was just generated in a recent JACC publication showing RHD mortality rates by county-based mortality data. And between 1980 to 2014, there were still 350,000 deaths attributable to rheumatic heart disease, with the highest mortality seen in Alaska, the South, and in the West, which tracks other health disparities in our country. Surprisingly, while most places were seeing decreases in mortality, there are still counties in the South where RHD mortality is flat or rising. Given this continued burden, one of our excellent residents, the first you'll hear from today, Dr. Tyler Bradley Hewitt, who has actually done 2 stints with us in Uganda, first as a medical student and then this summer as our community project, is going to talk a little bit about his REACH project on quantifying rheumatic fever in the U.S.
All right, a little different view up here. Just wanted to thank Dr. Sable and Dr. Beaton over the years, from when I was a little medical student to now being a little resident, kind of putting up with me in all the research efforts. But I think we've proven that there's definitely an enormous worldwide burden, and we have some evidence showing that there still exists some disease here in the United States. So we sought to further characterize the disease burden of rheumatic fever here in the United States using the KID inpatient database over the years from 2000 to 2012. There hasn't been too many recent studies showing data over time. So this graph here shows that from 2000 to 2012 and the 5 different reporting periods that we do still have anywhere from 330 to 550 nationalized acute rheumatic fever hospitalizations over the nation as estimated by the KID database. We also do see that this trend is going down. And this only accounts for kids that are hospitalized. The overall incidence in terms of rheumatic fever also is downtrending in the total population, as in 2000 is only 0.7 cases per 100,000 hospitalizations, and now in 2012 it's only 0.5 cases per 100,000 children. This might not seem like much, but the median rheumatic fever hospitalization total charges are about $12,000. And as I was kind of saying, that this probably misses quite a bit of the rheumatic fever burden, as most of these cases are treated as outpatient and diagnosed in the outpatient world. So, we already have those in there. So we also have a number of our ARF admissions vary considerably based on age, group, region, and ethnicity. We see the greatest raw number of cases in the South here, and that kind of correlates with the graph that we saw demonstrating higher rheumatic heart disease mortality in Alabama and Mississippi. Yet, somehow, we're seeing a greater percentage of hospitalizations occurring in the Northeast. There is no difference between males or females in the rheumatic fever hospitalizations in the KID. And we do see that Asian and Pacific Islanders were significantly overrepresented in rheumatic fever hospitalizations. They accounted for 7.8% of the hospitalizations versus only 2.1% in the overall KID database. And there is a graph suggesting that. Additionally, there's some emerging data not really accounted for in the KID that suggests even higher burden and disparity in the U.S. territories. This has at least some supporting evidence in Guam, Puerto Rico, and American Samoa. 2012 CDC report actually showed endemic rheumatic fever in children in American Samoa. They had 1.5 rheumatic fever cases of every 1,000 children, and 3.2 cases of rheumatic heart disease of every 1,000 children, reaching rates that are comparable to those seen in sub-Saharan Africa.
Thanks, Tyler. So if we believe that rheumatic heart disease is entirely preventable, why does it continue to affect millions of people around the world and a significant number of people here at home? Well, I would argue that our trouble actually starts with that phrase, rheumatic heart disease is entirely preventable, which started showing up in the 1970s in talks and literature about rheumatic heart disease. When the reality, as we just discussed, is that for many nations, there's been no progress made in reducing the rheumatic heart disease burden since early in the 19th century. So why is that true? So this cartoon gives us at least part of the answer, and I know you guys can't see well. So a police officer and a detective walk into a classroom where at least 4 dead cats are lying in front of a chalkboard filled with complex equations. The caption reads, "Notice the computations, theoretical scribbling, and lab equipment norms. Yes, curiosity has killed these cats. In the cartoon, the detective immediately deduces what has happened or has solved the case. And I would argue that we consider the rheumatic heart disease story to be a solved case. And what that leads to is that control is perceived only as a matter of good management, and there's been a stalling of research and thinking about rheumatic heart disease. So what evidence do we have to support this? Well, rheumatic heart disease has not excited funders. When you look at the big three in global health, TB, HIV, AIDS, and malaria, they cause 3 to 5 times more death than rheumatic heart disease, but receive 500 to 1,000 times more funding. Rheumatic fever is actually classified as a third-tier neglected disease or a microfunded disease, which receives less than 0.5% of the total global health research funding. And in 2014, we know things have improved since this time, rheumatic fever only received $1.4 million from 3 funders internationally. Rheumatic heart disease has also not excited the research community. If you look at publications in PubMed where rheumatic fever and rheumatic heart disease are in the title, you see at the peak in the 1940s to 1980s, there were about 2,000 publications a year, which fell dramatically after 1980 when we had solved the case of rheumatic fever here in the U.S. and is only beginning to uptake again. If you compare the 1,200 publications that happened here in the last 17 years on rheumatic fever and rheumatic heart disease, this compares to over 200,000 publications about the big three during the same time period. So, and what I promise is my last cartoon, a reminder that we may need to reconsider our assumptions. Here we see 2 pilots flying through dense cloud cover. The caption says, "Say, what's a mountain goat doing way up here in this cloud bank?" Like the pilots in this cartoon, when we think about how to tackle the remaining burden of rheumatic heart disease, there's a need to think outside of what we thought we believed to be true, to take a step back and to wonder more. In today's talk, we'll look how we at Children's National have been doing this in 3 ways. First, how we've looked at re-examining some of our long-held beliefs about rheumatic fever and rheumatic heart disease. Second, how we can apply modern techniques and approaches to understanding better the disease burden. And third, that we need to acknowledge that low-income settings are not just high-income settings that lack resources, and strategies that worked here in our country may not work as well or be acceptable in low-resource communities. So beginning again with wonder. So we'll start in some of the ways that Children's National has been involved in re-examining what we thought we knew about rheumatic fever and rheumatic heart disease. First, just a reminder of the neat way that we tend to package rheumatic heart disease into a very simple continuum, with each level dependent on the one prior. But the story of rheumatic heart disease is likely much more complicated than this, and there are major outstanding questions at each stage and on how these stages are linked together. So first, rethinking a little bit on what we think about group A strep and how it behaves. Well, strep sore throat remains a very common diagnosis in the U.S., about 5 to 10 cases per 100 child years, but our rheumatic fever rates have still plummeted. This leads us to 2 possible conclusions. First, that treatment is very effective, and we do know this to be true. Strep remains 100% susceptible to penicillin, but up to 1/2 of strep infections, even in our country, may not come to clinical attention. So this can't be the whole story. Second is that strep sore throat no longer causes rheumatic fever in the continental U.S., which is also likely true, although we don't understand why that's the case. And we still see that outbreaks happen, such as the one in Utah in the mid-1980s, where there was a high rate of conversion from group A strep to rheumatic fever. So it makes us wonder, does group A strep behave differently in different environments and at different points in time? And the real answer is that we really have no idea. There's almost no epidemiological data on streptococcal infections in sub-Saharan Africa and other endemic areas. So in the spring of 2016, last year, our team at Children's National began to explore this issue, attempting to capture pilot data on the carriage of group A strep and on the incidence of group A strep pharyngitis at 2 schools in northern Uganda. And from this study, we found 3 major findings. I also love the boys being so encouraging in the background. This is how you do it. So first, we found that carriage rates for group A strep were similar to what we see in the U.S. About 10% of kids were carrying strep in an asymptomatic way in their throats. But group C strep carriage rates was much higher. About 20% of children had group C strep, where the rates in the U.S. are reported at less than 5%. This is similar to data that had been reported in the prior year from Fiji that reported lower group A strep carriage rates but higher group C strep carriage rates. And in Fiji, they reported that 28% of their clinical pharyngitis was actually resulting from group C strep. Our clinical data on incidence is still pending, but we're waiting to see how much of our clinical pharyngitis came from group C strep. Those samples are still being processed. But it raises the question, and it started to raise the question, could group C strep also contribute to rheumatic fever development? We also found that group A strep pharyngitis was extremely common. So more than 500 children were followed for 30 days with 570 reported cases of acute pharyngitis in the school. Of these, 30% were found to be group A strep positive, again compared to a carriage rate of 10%, equating to 388 cases per 100 child years, compared here to the 10 to 15 cases seen in the U.S., Australia, and Fiji. This equates to a massive streptococcal burden in the community, with each child having 3.8 pharyngeal strep infections per year. Now, this data needs to be taken with a grain of salt, because when you look closer, this incidence data is heavily influenced by our day one results. In 2 separate schools in 2 different parts of the district, 20% of children reported a pharyngitis on the first day of our study, and 50% of those children were group A strep positive. We also see that those children, so reflecting that there's essentially no health-seeking behavior for group A strep pharyngitis. There was about a 3% absence from school on that day. On review of our data, we see that children have a milder clinical picture. Only 10% of kids had fever, and on a pain scale, the mean scale reported was 4 to 5 on the FACES pain scale for how they were feeling that day. We also see that as we began to treat children in these schools, the incidence dropped dramatically, presumably as we are limiting the spread of disease for the first time. Going down to the next step on the pathway to rheumatic heart disease, we also need to re-examine how we think about rheumatic fever. So historically, rheumatic fever was known to be a debilitating condition with severe arthritis, limited mobility, and a high rate of clinical carditis. But we're not seeing rheumatic fever in areas where RHD is endemic. So we believe the presentation may be milder. In Uganda, over 1,400 patients have been enrolled on a rheumatic heart disease, rheumatic fever registry, and of those, only 12 were captured at time of rheumatic fever. We also see in Uganda that 80% or more of adults who present with advanced rheumatic heart disease cannot recall an illness consistent with rheumatic fever, which is also seen in the indigenous Australia population, a little bit lower, but 40 to 50% of patients with rheumatic heart disease did not have a preceding rheumatic fever. So given this low rate of rheumatic fever detection and the high burden of rheumatic heart disease, we need to look again at our diagnostic criteria. And you'll remember from before that Dr. Jones intentionally designed these criteria to be highly specific. And as the AHA considered revisions of these criteria over time, they made them increasingly specific with each revision. But data started coming out around the 1990s that we may be missing a large proportion of rheumatic fever cases in the U.S. Specifically, in Fiji, it was found that monoarthritis was present in 17% of cases that otherwise met criteria for definite rheumatic fever. And when they did a retrospective review, 25% of children who developed rheumatic heart disease later had a missed rheumatic fever case because they had only monoarthritis at their presentation. We also see from Australia, when they did a retrospective review of their rheumatic fever cases, that only 25% of those cases had a fever of 39, the previous cutoff, where 71% of cases fell between 38 and 39 degrees. And over 25 studies between 1992 and 2015 showed that subclinical carditis, or carditis you could only see on echo, predicted long-term cardiovascular morbidity, previously not included as a criteria. So these findings led the AHA to conduct another revision in 2015 to take into account the need for more sensitive criteria in endemic areas. Dr. Sable and I had the pleasure of working on this group, and we ended up with 3 major changes to the Jones criteria. The first was the subdivision of the criteria into a low-risk and a high-risk group. The second was addition of subclinical carditis or echo-diagnosed carditis as a major criteria for all groups. And the third was increased sensitivity in the moderate to high-risk group through lowering our criteria for joint involvement, lowering our fever, and our laboratory thresholds. So at Children's National, with new funding from the American Heart Association, we've established a strategically focused research network on rheumatic heart disease, and are undertaking the first epidemiological study of rheumatic fever in sub-Saharan Africa. This is the first large-scale study to prospectively apply the new Jones criteria in a high-risk population, and we're hoping to characterize what rheumatic fever looks like in a high endemic area. Locally, our enrollment will occur across 4 districts in Uganda, where posters such as these are alerting the community about the importance of joint pain and fever, and widespread radio announcements are calling families to bring their children in for evaluation. We've also started universal education of the healthcare workers, the village health teams, and the schools in this district in order to capture cases. And in addition, to our excellent on-ground team in Uganda, you'll see lots of people you recognize here. We've assembled a multidisciplinary team at Children's National for expert case review with telemedicine and photo upload through RedCap, serving as a bridge to assist with nearly real-time case evaluation. And very preliminarily, we started enrollment in our northern district. We see that fever and joint pain are very common. This is our weekly enrollment since the end of June. We've enrolled 90 cases over the past 14 weeks at this first site, and preliminarily, using the Jones criteria, 30% of these actually meet criteria for rheumatic fever, suggesting poor health-seeking behavior and lack of diagnostics may be driving our lack of rheumatic fever on the ground. Obviously, a lot more data to come. Next, we'll look at a few ways that Children's National is using modern technologies to improve our understanding of rheumatic fever and rheumatic heart disease around the world. You can see all the way back to the original writing of Jones that his clinical criteria were only meant as a placeholder in anticipation of a soon-to-come diagnostic test for rheumatic heart disease and rheumatic fever. However, there's been no progress made towards a confirmatory test, which is why we continue to rely on this clinical decision rule. As an additional aim of our strategically focused research network, we've partnered with collaborators in Australia to develop a biological signature for rheumatic fever. In preliminary work, we see that by plasma protein expression, cases of rheumatic fever in pink cluster away from cases who are normal, and we'll be using metabolic and transcriptomic analysis to try to find a confirmatory test panel that can distinguish patients who have rheumatic fever from those who do not. Additionally, we've known for some time that the risk of rheumatic heart disease runs in families. All the way back to 1960 in studies in the Israeli kibbutz, it was found that parents that had rheumatic heart disease, that their children had a 2.9 times higher risk of rheumatic fever, even though they were being raised separately from their parents. And pooled twin studies show a heritability of 60%. We had looked at this in Uganda using an echo screening study of children who had latent rheumatic heart disease, inviting them to bring their entire families, as well as the families of age and gender matched peers, to see what the risk of latent rheumatic heart disease or echo-diagnosed rheumatic heart disease was in families. And what we found is that if one sibling in a family had latent rheumatic heart disease, then their siblings were at a 4 to 5 times higher risk of also having latent rheumatic heart disease. And the picture you see there is an echo study of 3 family members, all showing significant mitral valve pathology, a mother and her 2 children. But we're just starting to see research emerge in this area using genome-wide association studies to look for protective and susceptibility factors to help explain why this is so. The first published study came out this year implicating a variant in the immunoglobulin heavy chain locus as a risk factor for susceptibility. And here at Children's National, we've partnered with the National Human Genomic Research Institute to conduct a study in Uganda, with our preliminary work revealing a GBL1 variant, which codes for the elastin binding protein, to confer protection against rheumatic heart disease development. We currently have a replication cohort underway for this study and have partnered with the Fijian investigators to replicate their findings in a distinct population. And we're part of the International Rheumatic Heart Disease Genetics Consortium that aims to do a pooled data analysis multinational by the end of this year. It would not be an overstatement to say that echo, more than any other factor in the last 5 to 10 years, has elevated the profile of rheumatic heart disease and led to increased funding and advocacy around the world. The first major contribution came in 2005 when a New England Journal of Medicine study published that we could find 10 times more rheumatic heart disease if we looked with echo rather than trying to diagnose these cases clinically. And the graph there is what you see, a rapid succession of studies that replicate these findings, with the amount of rheumatic heart disease prevalence detected in light blue clinical and the dark blue by echo. This is where, as Dr. Sable mentioned, I was able to plug in as a fellow and get involved. undertaking an echo screening of 5,000 school children in Uganda, and now to date, over 15,000 kids in Uganda have been screened as part of other research studies and epidemiological surveys, finding a pooled prevalence of 2.7% of children showing evidence of early rheumatic heart disease when we look by echo. Of great importance, we've also looked at the burden of rheumatic heart disease among pregnant women and are currently studying the impact of rheumatic heart disease on maternal and fetal outcomes. So between 2015 and 2017, in a separate American Heart Association grant, we screened over 3,500 women for heart disease by nurses at level 3 health facilities. The study showed that 1.6% of women with heart disease during pregnancy, and that 84% of those women had advanced rheumatic heart disease. Interestingly, only 2 women in that study knew about their diagnosis prior to this study, and there were a significant proportion of these women that we were following that developed significant cardiovascular symptoms and required medical intervention or referral to tertiary care. And while our outcomes tracking is still wrapping up, we're waiting for the last of the women to deliver. Rheumatic heart disease seems like it may be a significant contributor to indirect or non-obstetrical maternal mortality and to poor fetal outcomes in these regions, which may help us advance our fight against maternal and child mortality. That piece of the pie, that indirect maternal mortality, is very poorly understood, so this contributes to that knowledge. We've also started to look at what the burden is at the community at large. So under the leadership of Amy Scheel, who you'll hear about in a moment, we undertook the first community-based epidemiological study of rheumatic heart disease in sub-Saharan Africa this summer. And Dr. Jen Klein spent her post-residency graduation with our summer in Uganda, and she'll tell you a little bit more about her project.
Thank you so much. Again, my name is Jen Klein, and it was my distinct pleasure to be in Uganda this past summer as part of the community prevalence study. There we go. So in a few moments, you'll see some pictures and see some video footage from our project. But first, I wanted to tell you a little bit more about our study and how we accomplished our goal of gaining an understanding of the true prevalence of rheumatic heart disease in northern Uganda. The estimated prevalence in Uganda is somewhere between 1.5% and 4%, but this number is based on modeling from pool studies and from patients presenting to the hospital, and thus is not truly representative of the larger population. And this household study provided the first real data on prevalence of rheumatic heart disease in northern Uganda, and more specifically about adults as well. And so just as you've heard how our understanding of rheumatic heart disease is evolving, so are our methods of finding latent cases of RHD. Our team this summer consisted of trainees, non-cardiologist physicians, myself included, local volunteers, and supervising cardiologists. And each day we would visit randomly selected households in enumeration areas or villages as identified by the red stars on this map. All household members between the ages of 5 and 50 were eligible to be enrolled in the study, and that included collecting demographic data, some socioeconomic information, and of course providing rheumatic heart disease screening by echo on handheld tablets that were equipped with echo capability. The data analysis is ongoing, but preliminary results show about a 2.5% prevalence of heart disease, 77% of which is rheumatic heart disease. And so with the use of this portable echo technology, as well as the use of non-cardiologists to provide initial screening, the model of rheumatic heart disease research is shifting. And as I know Dr. Beaton will say in a minute about how the face of RHD is shifting as well. So we will now show you some of those faces.
For those of you who haven't been part of a field project in a low-income country, we just wanted to put a little bit more of a face on what it looks like when we get all of this data. Continuing on our talk, as echo screening has revealed a large burden of latent rheumatic heart disease in these communities, seen here at the bottom part of this pyramid, the natural question is, how significant is that finding on echo? How many of those children will progress up this pyramid to clinically significant disease? And can early detection and penicillin prevent progression? So we started to answer this question by looking at our longitudinal follow-up data of over 200 children with rheumatic heart disease found during our screening studies. The follow-up was a median of 2.5 years, but a significant portion of children have been in the study more than 5 years. And what we see is that latent rheumatic heart disease is a heterogeneous condition, just like clinical rheumatic heart disease, with a lot of variability in outcome. There in green, the children who improved, yellow who stayed the same, red who progressed over the study period. We also see that children found with moderate to severe disease in the community really should be considered missed clinical cases. This is a failure of the health system to detect these cases. These children have poor outcomes even over 2 years, with almost 10% having mortality at the 2-year outcome. And finally, we see that natural history data may never answer the question about penicillin in this population. There's just too many confounding variables. Even when we tried our best to control for those, we found that penicillin increased the risk of progression in our study, which is counterintuitive and tells us that what we really need is a randomized control trial of penicillin in this population, and it's exciting to announce that we heard we have funding to conduct that study as of Monday. So that's to determine. Thanks. Finally, really quickly, we'll look at the work Children's National has been doing to ensure that our research translates into both effective and acceptable solutions in low-resource communities. So to briefly summarize what accounts for about a dozen studies over 2 to 3 years involving many of you in the room, the answer is that we can probably make echo screening practical and affordable in low-income settings. We know that handheld echo provides reasonable sensitivity and specificity, which lowers our costs dramatically and increases the reach and portability. We know that we can train non-physician healthcare workers and nurses to quickly and accurately assess for rheumatic heart disease in the community. And we know that we've developed reliable training methods that are asynchronous and require very little hands-on training to provide the skills needed to conduct these echoes in low-resource communities. Ongoing data is still out on our work in direct cost-effectiveness analysis and on diagonal planning so that we can move these siloed programs into the existing healthcare infrastructure. What we really were interested in is echo acceptable in these low-resource communities? So in 1994, the Council of Europe published criteria for the acceptability of diseases appropriate for screening. And part of this said this approach must be acceptable to the population. So we looked at from a children's perspective, and when we did screening, 95% of children were pleased their hearts were checked, and 98% would tell a friend to have their heart checked. But we were surprised that 50% actually would like more privacy. You can see from our project we don't have a lot of privacy involved, and over 50% felt scared, which is perhaps not surprising. We also found from a teacher's perspective that 89% thought parents were happy about the screening study, and 100% would tell other schools to participate. But again, there were significant concerns about the children being afraid, and the screening was disruptive to classroom activities, reported in 70%. So we've integrated some of that feedback, which was in 2015, into our screening programs going forward. We also wondered if screening was affecting children's quality of life, because disease data from other pediatric screening programs suggests that just screening for a disease or finding children with asymptomatic disease can lower quality of life. This is another one of Tyler's projects as a med student. And what we found was preliminary diagnosis of rheumatic heart disease preliminary screening for rheumatic heart disease did not change quality of life. But being diagnosed with latent rheumatic heart disease, even when these children were largely asymptomatic, decreased both their physical and emotional functioning scores. So Amy Shiel, who I mentioned earlier, is the planner of our community project, was living in Gulu, Uganda for 2 years working on another project when this data came out, and in response she had the idea to start a peer support group, and I'll let her briefly explain the results that they achieved.
Hi, everyone. I just first want to thank Dr. Beaton for allowing me to be here to participate today, and also just echo Dr. Sable's comments about her being a mentor, because she has been an absolutely amazing mentor to me over the last 2.5 years, as well as supporting me through my first larger primary project, the community study, which you saw moments ago. So can providing education and support help us address this decrease in quality of life seen in children diagnosed with rheumatic heart disease? So to answer this question, we launched a peer support group in Gulu, Uganda in January of 2016 to see if participation in the group could lead to increases in quality of life as well as social support and disease knowledge. So this group met monthly for 6 months and was attended by 50 children with definite rheumatic heart disease who are also receiving monthly injectable penicillin. The group started with a warm-up of light aerobics, as you can see on the right, and then children rotated through support and educational programming, and it ended with a team-building activity. So the educational programming was designed to impart knowledge about rheumatic heart disease, as well as dispel fears and misconceptions commonly voiced by parents and children attending the cardiology clinic. The support element consisted of a team-building activity followed by another craft or activity to promote an unstructured discussion about the child's experience with rheumatic heart disease. So as you can see on the left, children had to pass a hula hoop around in a circle without unclasping their hands. I promise if you're over 4 feet tall, it's a little harder than they make it look. And then they were asked the question, what challenges or hoops have you had to jump through as a result of your rheumatic heart disease diagnosis? So can this education and support help? Our answer is absolutely yes. So after 6 months of support group participation, we noticed significantly improved quality of life scores, including significant increases on 3 of the 4 subscales of the PEDS quality of life scale. In addition, we saw significantly decreased feelings of social isolation, increased rheumatic heart disease knowledge, and improved adherence to therapy. In addition, our clinical nursing staff, who are also group facilitators, noticed qualitative indicators of improved social support, noting that children were attending injection clinics in groups when a lot of them had previously come alone. In addition, we have found that our participants are community educators and would commonly bring their family members and friends into clinic if they were suffering from a sore throat. So the results of this study really promote the implementation of support groups with RHD screening and clinical programs. And as a result, this group will serve as a model for the support groups that will be used in the clinical control trial that Dr. Beaton just mentioned for kids that are diagnosed with rheumatic heart disease, just further demonstrating the unique interplay of the projects that we have ongoing in Uganda.
All right, so to wrap up, I wanted once again to emphasize the total of this work has really only been possible because of the team that exists here at Children's National and around the world. And I wanted to thank the wide range of physicians and trainees and nurses and staff that have given their time and resources to advocate for this work, to support it scientifically and financially, and to volunteer their time and talents both here and abroad. And instead of trying to list everyone, I thought I'd just real quick have everyone raise their hand who's participated in this program in any way, as a show of the wide team support we've had. Hopefully a lot of people are here. Okay, so it's okay. I counted over 50 people at Children's National who had been involved in this work in some way, and we've so appreciated everyone's support. So in closing, it's important to remember that rheumatic heart disease is not a solved case. So for an example, 2 11-year-old kids presented in 2015 with severe rheumatic heart disease. Despite what we think we know about this disease, neither could recall a notable pharyngitis, and neither could recall an illness consistent with rheumatic fever. The difference between these 2 children, Angie lives in northern Uganda, and Prince has never left the United States. In Uganda, where Angie lives, 1 out of 27 children shows evidence of at least early rheumatic heart disease. Children's National is leading the global efforts to rethink what we know about rheumatic fever and rheumatic heart disease, because investing in research in endemic populations can help close the knowledge gaps that result in RHD persistence in the United States and develop solutions that will improve the health of children around the globe. Thank you.
Wow, that was really an outstanding presentation. Thank you so much. And integration of the trainees was really very special. What you talked about really conceptually is the identification of a chronic disease in a low-resource population, implementation of screening tests to identify the prevalence in those kids with it, and then implementation and sustaining an ongoing intervention to prevent progression of the chronic disease, right?
Correct.
So I'm sort of curious, there are similar chronic diseases in the United States that we still struggle with in that regard and around the world. What can you tell us, how optimistic are you going forward that you can develop a program that can be sustained? Do you have the local support, for example, from public health authorities? And how exportable or translatable do you think that model is going to be across sub-Saharan Africa and into India and elsewhere?
It's a really good question, and something that I didn't talk about is the rising tide of global advocacy and support for this disease. So just this year, the World Health Organization re-elevated rheumatic heart disease onto their list of priorities and set targets for international reduction of the disease. And a communique came out of the Pan-African Society of Cardiology that set 5 research priorities that all of the leads of the Ministries of Health of Sub-Saharan Africa have signed on to. We actually have a lot of buy-in from the government and the community in Uganda. It wasn't able to feature as well, but the Ugandans are lead author or primary author on most of these publications with us. And we have a stakeholder summit, that's a good question, approaching November 2nd and 3rd to bring together the ministers of health from sub-Saharan Africa, from the countries right around Uganda, as well as key leaders in the Ministry of Health in Uganda to set an agenda going forward in that country of how we're going to approach this disease based on the data we've been gathering over the last 5 years. So we're hoping to come up with progress that's sustainable, but it's hard, it's always a challenge.
Thank you, Andrea. Wonderful presentation. I have a question about prevention, and I think that probably goes back to streptococcal infections. I'm just wondering whether, with the mass drug administration that's being performed in many of these countries with medicines like praziquantel, azithromycin, and ivermectin, whether that's having any effect, specifically the azithromycin, and if there's ever been any thought of doing a mass drug administration of penicillin the way Yaws was approached 60 years ago.
It's a really good question, Scott, and thanks for your help on our rheumatic fever project right now. I have 2 different comments on that. The first is that we think that mass drug administration for other diseases is controlling at least the skin infection portion of this in Uganda. So when we did our strep study, we screened over 3,000 children for skin infections at the same time. Based on the data out of the Pacific, that over 20% of children had active impetigo, and the majority of those children had group A strep, thinking that in the Pacific, skin infection was contributing. And we found almost no bacterial skin infection, about 7 or 8 cases out of those 3,000 children. And what we learned is those children were living in areas who had had mass ivermectin administration, and new data has emerged that ivermectin also treats scabies when given in that way, so reducing the risk of skin infection. So in Uganda, at least, we think it's not contributing, and that there's potential for those strategies to reduce the burden in other areas. The second question about mass drug administration is interesting because there was pilot data that children with HIV had lower rates of rheumatic heart disease. And when you looked, all of those children had normal CD4 counts and were linked to care. And so the question came up, could the Bactrim prophylaxis they were receiving prevent rheumatic heart disease development? One of our fellows, Ian Hovis, who's getting married this week, so couldn't talk today, just finished a replication study in a larger population of children with HIV from Uganda that's proving the same point again, that we see less rheumatic heart disease in that population that is already linked to care and receiving treatment, ARTs. So our question is it something related to the immune system? Is it something related to the mass drug administration or the prophylaxis they're receiving? Or is it their linkage to good pediatric care, which doesn't exist during the sort of around the rest of the country? And we just don't know yet. But it's an interesting question and something people are thinking about around the world.